2020 in these strange times. Normally, myself, Professor Darzi, and Professor Hannah would be welcoming you in London, but unfortunately, because of the COVID pandemic, we've had to reinvent and adapt to the new challenges posed by COVID-19. So this year we've organized a 2-hour webinar, which will hopefully be as stimulating and interesting as our usual live events. So without further ado, I'd like to hand over to Prof. Darzi for some introductory remarks. Thanks, Prof. Darzi.
Thank you, Ahmed. Can you hear me? Yeah. Thank you very much, Ahmed, and welcome all. Lovely to have you at this virtual symposium, and also to joining this 2020 London Surgical Symposium. I think Ahmed just mentioned the word COVID, which has really disrupted our lives across the globe, but we still felt that a virtual event is very much a worthy thing to do and provide us with the opportunity to showcase the world-class research innovation that are all of us developing across the disciplines of surgery. I'm also delighted that it's not just the Faculty of Medicine, other faculties have joined us, but more importantly, many other universities in London and beyond have made a significant contribution to make the program very engaging and rich in its content. I think it's worthy to remember all our clinical colleagues, including many surgeons who put their lives at risk working during the first peak or the first wave of COVID in this country and beyond. And we all know many lost their life, including surgeons, as a result of COVID-19. We certainly lost at Imperial College Trust number of colleagues, both physicians and nurses. And again, it highlighted to, certainly in this country, the contribution that the NHS and many of our clinical colleagues have made in terms of managing this dreadful disease that has completely changed our life upside down. One other thing, considering this is a research symposium, and I really want to make this point, many of the PhDs and the research fellows who were really there doing their usual research also had a huge disruption to their research, but at the same time made a significant commitment to volunteer and help during the difficult times as we move into the next wave. So I'm sure you'll all agree we should always remember those who were there in some of the terrible months of March, April and May. On a more brighter note, the London Surgical Symposium has been running now since 2006, so this is its 14th year. We've always invited some of the most eminent speakers and world-class surgeons to share their wealth of knowledge, and some inspiring ideas have been presented at this symposium. Also, it's a great privilege for some of us who worked at St. Mary's that we are also hosting the esteemed 9th Hugh Dudley Memorial Lecture. These things don't happen without the commitment of many people, and I'm really very grateful to Ahmed and many of the administrative staff, and certainly George Hanna as the head of the department, to ensure that we continue to engage our academic and clinical colleagues. And this, it's a day in the calendar that we always appreciated to see. Sadly, we're not together, but I think a virtual event should be able to address that. I'd also like to thank our sponsors, Ethicon, who have enabled today's proceedings. We have a very stimulating program. Firstly, let me start by talking about the 9th Hugh Dudley Memorial Lecture. And I couldn't think of a better colleague who I haven't seen for many, many years, and that's Simon Paterson-Brown. And I've just asked him the question, when was the last time we worked together? And his memory was 2002 or 1992 or 1993, if I'm correct. He was the surgical registrar working with Jeffrey Glazer, who I'm sure is online. and I happen to be working with the academic surgical unit. There were very, very different times. And I remember Simon sadly leaving us in those days and being appointed to an amazing job in Royal Infirmary in Edinburgh. And he's going to share his passion and interest on surgical training. And he's going to specifically speak today, training in stressful environments. I'd also like to hear, we're going to be hearing later on from Patricia Sylla, colon and rectal surgeon, Mount Sinai Hospital in New York, on quality assurance in surgical clinical trials, challenges in rapidly changing global landscape. So to kick off today's symposium, I'd like to introduce our first distinguished speaker, and that's Dr. Jack Bonier, to give our first lecture. Dr. Bonjer is a professor of surgery and chair of the Department of Surgery at the Amsterdam University Medical Center. He is also the founder and CEO of the Amsterdam Skills Center for Health Sciences, which opened in 2019, for which he received the 2019 Amsterdam Impact Award for Life Sciences. He will speak to us today on digital scope on surgical training. So I'd like to extend my thanks to all of you speakers today and the contributions that you're going to make over the next 2 hours. And I hope everyone in the room, or wherever you happen to be, probably in your own homes, to enjoy this afternoon. Thank you very much.
Thank you, Prof. Darzi. One quick housekeeping point. We really want this event to be useful to everybody, and there's a live Q&A interactive section that you can use. So most of you will, on your bar, on your Teams app, will see a question mark with 2 small bubbles. So if you click on that and ask any question you wish, I will pose them to the lecturer. So please go ahead and use that live facility for interaction. Thank you very much. Without further ado, I will leave the floor now to Dr. Jaap Bonjer. Thank you very much.
Even kijken, verder. Ja. Well, it's a great honor to be invited to speak at this symposium. First technical check whether you can see the first slide. Okay, Pat is saying yes. That's good. And now I got to see it myself. Okay, and thank you, Professor Darzi and Professor Hannah, for the kind introduction. It's great to be here. And of course, I miss not seeing you in person, but this virtual symposium is a very good substitute. I'm looking forward to a great interaction. The topic of today is digital scope on surgical training. And as Ara already alluded to, there has been a major impact of COVID on our surgical practice, and our surgical residents have had to swap the OR for emergency triage, work in the ICU, very difficult work, very taxing situations. We've seen a severe decline of surgeries, and we also have seen surgical faculty taking over cases to make them go faster and get more cases done in a short period of time. A recent survey in the US showed that 80% of all surgical residents did not go to clinic anymore during the COVID crisis. And 40% of those who were surveyed expected not to meet the ACGME case requirements. So this is very serious, and we're all concerned about it, particularly concerned because Amsterdam is, as we speak, being hit by a second wave. So we've been very busy today reducing the elective surgeries again, to our great regret, of course. Aside from regrets, it's also time to reflect and to ponder on the way we provide surgical training, because we're confronted with a vast challenge in these times. I would like to, in the coming 15 minutes, speak on the evolution of surgical training, give you a short overview of digital learning resources, and pitch an idea, a concept for next generation surgical training. I trained myself at the University Hospital in Rotterdam between 1987 and 1993. So, like Professor Darzi and Professor Hanna, we worked 180 to 100 hours per week. Did many cases. In the Netherlands, there was no final exam, and after 6 years, I graduated as a surgeon. This is called time-based residency, which is a bit of a fancy term for just locking up a resident for 6 years in the hospital, and when the resident comes out, he comes out as a surgeon, an internist, or a gynecologist. In 1993, the European Working Hours Directive was implemented, talking about timing, just at the end of my residency. And we changed from an 80 to 100 hours work week to 48 hours per week, including call. So we had to change the whole system. And in the Netherlands, we were inspired by Professor Olle ten Kater from Utrecht, who introduced competency-based medical education. And we adhere to the 7 competencies proposed by Richard Resnick from the University of Toronto.
Sorry, Doctor, could you press share again?
We reorganized surgery. We subspecialized more in surgery. We did not all complete the residency as a general surgeon. So currently the first 4 years of surgical residency in the Netherlands are general training, and the last 2 years are years of differentiated surgery, varying from vascular surgery to pediatric surgery. We felt it was necessary to assess the competencies and again looked at Toronto and introduced the OZs you're all familiar with. And also started many years ago a digital portfolio, which provides an overview of the OZs, progress interviews, the score on the app site, etc. And this is an example of the electronic portfolio that we have for all residents. This is an example of which competencies should be acquired by the second year of training. So appendectomy should be able to be performed under limited supervision, and also reduction of a closed fracture. You may think that this is a typing error, but in the Netherlands, the general surgeon still takes care of fractures. So is competency-based training the solution? Well, there of course was a lot of criticism about the administrative burden filling the portfolio of the resident. Brooks mentioned that the sum of the competencies would be more interesting, and of course he was right. It is not about the individual competencies.
Dr. Bonjer,
introduced then the EPAs, entrustable professional activities, and they resemble a more holistic approach to the workplace and combine different competencies. There are different levels of entrustment, akin to the levels of OZs, varying from no permission to act to provide supervision to junior trainees.
Professor Bonjer, your slides are not advancing.
I think we might have lost him. Oh,
and the EPAs, are those together the holy grail? Well, I don't think so. Because let's think about how long it takes to build a surgeon, to build a gynecologist, to build a neurologist. In the time of the Georgians, it took 14 years, and in our times, it still takes 14 to 15 years, starting at the bachelor phase of the medical school. We still have a master apprentice model. We've partly digitalized it, but a very modest part, and at a high cost of 2 million euros. So how does that pin out in hours? So 15 years of training, let's say 40 weeks per year. Wing, and then you go to the helicopter, 8,000 hours. And to become a surgeon takes 30,000 hours, and that's probably even lowballing it. So why is that? Well, we all know why that is. Because we learn on stage, the service education ratio of our residents is still a concern. It has dropped, but I think it needs to drop more to create more time for education. And we have used simulation in a very limited way. We all agree that surgery is top sport, it's team sport, and many of us are great soccer fans. And when you play soccer, you don't practice during the World Cup final. You can see some pictures of World Cup finals where the Dutch excelled, but didn't win. This is a painful moment. So shouldn't we, like the soccer players, train outside of the World Cup final, outside of the OR? Well, over the weekend, I reviewed the literature and looked for EPAs of the job. Do they exist? I came across one, and I would be interested if you can allude more to me. But this is a clinical pathway for foregut surgery, which was developed at the University of Pennsylvania. It encompassed 3 days of training, utilized Symbionix GI Mentor, gastrojejunostomy on porcine tissue. Altogether, faculty taught in blocks for 4 hours and a cost of $3,000 per resident. The residents did appreciate it, the small group learning. What they did not appreciate were the mock patients, because they felt they were through that phase after medical school. And what was also reported was an interruption of clinical service and the amount of time that had to be invested by the faculty. So these are the problems: interference with clinical duties, the presence of a faculty, and one needs most of the time costly training facility with simulators, animal or human tissue. So what we need is a digital learning environment at our fingertips. I want to show you the fantastic development of touch surgery developed by Dr. Jean Nemi and Dr. Andre Chow. And they have built, I think, a phenomenal app which has a responsive user interface. It allows you to assess your progress and also to archive your progress. And this app is open access, which is also very important. So this is a very useful tool, and as you know, digital surgery, which is the new name for touch surgery, has recently been acquired by Medtronic, is a very good tool to use, but it is only an app for the cognitive competencies of the learner. It does not provide hands-on learning. The app is used by many surgical residencies across the world and has been validated, and this study was on the validation of touch surgery for laparoscopic cholecystectomy. Construct validity was shown in this study. It was compared to touch surgery app with the Symbionix simulator, and what was interesting, when you first trained on the Symbionix, it did not improve your performance on the touch surgery app and vice versa. So the two seem to be complementary. Another validation study took place in open carpal tunnel release. And again, construct validity was shown. And you can see some pictures how you can drag the incision point on the screen, which makes it truly interactive. There are many platforms for digital information, for digital videos, and I would just want to mention a few. One is the AIS channel by Antonio Lacey, set up very, very well, and provides a wealth of videos, more than 200 videos. MedSoup is probably the largest, with almost 16,000 videos in 5 different languages. And we all know web search, and Jacques Marescot was, of course, the first to start this training center. And web search also provides an enormous number of videos on surgical procedures. And then there's this Amsterdam-based company Incision, which has provided 3D videos, a total of 300. Here in Amsterdam, at the Amsterdam University Medical Center, Jochem Bretschneider, who's an ENT physician, has also worked at Apple and developed iBooks, which are available on iTunes U and can provide the medical student and the surgical student with valuable information. So there is a wealth of information out there, but will that be sufficient? Only can we train surgeons in a digital way? Well, I don't think so. We still need hands-on training. And we all agree as surgeons that practice makes perfect, but do we need clinical practice? Well, at some point we need clinical practice, but there are also other solutions for hands-on training. And here you can see the board of the American Board of Surgery. It's president at the time, John Hunter, who is still captivated by the laparoscopic suturing box. So the box is still a very useful tool, and Sages has also done a phenomenal job with the FLS box. In Amsterdam, together with the Technical University in Delft, we have developed this 4Sense laparoscopic training box, which is connected to a website. So the accomplishments of the residents are uploaded on the website, and the director of the training program can review the progress of the resident. And the residents here in Amsterdam get this carry-on, which contains this training box to take home. So they train at home in their off time, and we can follow them from the hospital. What about VR simulation? We've been on this now for more than 20 years, but we're still it's still hampered by poor graphics and a lack of tactile senses. I've come across a few years ago about this cataract simulator, which was built by Moog, previously Fokker, and this was built for Help Me See. And Help Me See is a foundation that has performed over 300,000 cataract surgeries in low and middle income countries. And this simulator has a fantastic haptic feedback, and the picture, as you can see here, is very realistic, and this is an animated picture. This simulator offers 20 different scenarios of a cataract, and experience has been gathered in Madagascar and in Mumbai, and it has turned out to be possible to train basic medical doctors or nurses in 3 months' time to become a proficient cataract surgeon. So this simulator is the disruptive change that we need. So here at the Amsterdam Skills Center, we distinguish the following steps: e-learning, followed by box training, followed by training on the simulator, and then training in the wet lab on human cadaveric tissue here in Amsterdam. With the progressing technology and the improving haptics, it will be more possible to train on a handheld device rather than on a very expensive simulator. So we believe that the mobile training will move more to the right side as we go along. Once the trainee has gone through all the steps, it's time to go into the OR and perform the surgery, being tutored by a surgeon. and a very good possibility for follow-up mentoring is this pair of glasses, which allows someone at a distant site to see what the surgeon is seeing and then annotate on the screen. So, coming to the conclusion, in the past years we've adhered to training on the job. Before the year 2000 it was all time-based training, and between 2000 and 2015 we provided competency-based training. As I told you, in 2015 we started with EPA-based training, and I believe it's now, certainly with the COVID crisis, it's time for a paradigm shift of the mindset, and we need to move to training off the job in a digital, scalable way and build together an EPA-based blended training program. So this is a call to action to strike a global academic consortium to build together an off-the-job EPA-based blended surgical training module. Thank you very much.
Thank you very much, Dr. Bonier, and I must congratulate you. The talk was fantastic. Probably you're not aware, but the audience wasn't able to see your slides during your presentation, but despite that, your message came across extremely eloquently and very clearly. Are you able to answer some questions, if I can pass them over to you?
Yes, absolutely.
First of all, from myself.
And I just understand from people from Philips that the slides were not showing, so that is.
They weren't, but your presentation and your clarity was superb. So thank you very much. The message was perfect. Okay. I'd like to ask you.
Never have to make any slides anymore, so that's good.
Exactly. Yeah. First question I wanted to ask you is, with the training programs that you offer in Amsterdam, can you envisage the scenario that you can take non-medically trained people, but people who are good at hand-eye coordination and tasks, and basically train them to perform surgical tasks without them needing to have medical training?
Yes, well, what I mentioned, the training takes far too long. It takes 15 years, and I do not know of any other job that you need to train for 15 years. So I think we should rethink our surgical curriculum. And here in Amsterdam, we're working at building a curriculum for a so-called essential surgeon, so that is someone who can perform the essential surgery in the low and middle income countries, such as a groin hernia repair, laparotomy for acute abdomen, managing a fracture. And we believe that we could train basic medical doctors in 6 months' time to become an essential surgeon when we only focus on surgery and not let them do any service. And what I mentioned, there are so many digital learning resources, and when we work together and put those resources together in an integrated way and combine them with simulation, I truly believe that we can do it in a much shorter time than the 15 years that we're dealing with now.
Brilliant, thank you. One question from the audience. What role do you think cognitive task analysis plays in surgical training?
Yeah, well, it has been shown, I didn't show that study, that the cognitive training allows you to perform the surgery better and learn it more quickly, but it cannot stand alone. That was also shown in the one study on laparoscopic cholecystectomy, that you need the hands-on training together with the cognitive training. So it should go hand in hand with VR simulation, followed by hands-on training in the lab.
Fantastic. Thank you very much indeed. I will now open the floor to our panelists. Would anybody like to ask Dr. Bonjer any questions?
Jaap, that was a fantastic talk, despite the slides. This is how gifted of a lecturer you are.
You saw one slide, I
yeah.
think. Very nice. Yeah.
I have a quick question. What is your feeling on, this emerging, not so much emerging concept, but this concept of, in a way, triaging surgical residents based on their baseline aptitudes, cognitive and technical skills?
Yeah, this is a sensitive topic, Pat. Are we allowed to select residents at the beginning of their training based on their competencies? And we've discussed that at great length here in the Netherlands, but we have never gotten around to truly testing them. When I applied for the surgical residency, I had to spend a day at the psychology bureau and had to do all kind of fine motor tests, but we moved away from that after that. So I'm curious how you handle this in the US.
It's also extremely controversial.
Yeah.
We know some programs during interview process actually will ask applicants and will give them a box, almost like an FLS box, and essentially ask them to complete some tasks. But it's not obviously on a general scale. It's really per institution. But it's a very controversial, but something to think about in the future, especially if you're thinking about expediting, shortening the training program. Some people we know are going to learn and acquire the skills much faster than others. But he opens up a whole box of uncertainty about how you select and the biases and all these things we're trying to move away from. So yeah, hot topic.
Indeed. Well, thank you, Dr. Bonier, very much. Fantastic talk. We will make your slides available later on the website. In the interest of time, I think, Pat, if it's okay with you, I'd like to ask you just to carry on with your talk on quality assurance in surgical clinical trials, challenges in a rapidly challenging global landscape. Dr. Patricia Sylla, thank you very much indeed.
Well, thank you very much. Let's make sure my slides are working first. So maybe I'll just open, hold on one second. There we go. Can you see my slides?
Yes, and can you advance it just so we can see that it goes? Yes, perfect.
Okay, wonderful. So thank you. This is really a great honor to have been invited to participate in this this symposium. It's really a spectacular, and I congratulate you to carry on with virtual meetings, and it's really a pleasure to contribute. And I also like the take and the concept behind the symposium being really focused on quality assurance, especially in these trying times. I think it's important to stay focused on quality, not only of maintaining surgical training, but also carrying on research and making sure we don't cut corners and compromise the quality of our efforts. So I was asked to focus on quality assurance in the setting of surgical trials, and this is definitely challenging. It was challenging before COVID, and it's even more challenging now. And I'll touch on some of those issues. But first, sort of take you, to the basics of surgical trials and how to maintain quality assurance. These are my disclosures, which are not relevant to this talk. I will mention two companies at the end of my talk, but I do not have any financial interest in either of them. So surgical trials obviously are very important. Why do high quality surgical trials matter more than ever? We know that the main impact of surgical trials is that they affect clinical practice. We actually have a chance of changing the way we do things because we have high quality evidence to convince us of the need to change. So the big question really comes down to, when you talk about randomized controlled trials, is what is the minimal level of evidence that we need, that our surgeons need to agree to change their practice? And I think it's really important to also keep in mind, and now especially with the emergence of a lot of new technologies and procedures, that we have an ideal framework, and you all know about the ideal framework, but we have a solid framework to be able to evaluate the safety and efficacy of these technologies. So randomized controlled trials remain the gold standard. There's no going around this. It is still the best methodology to reduce bias, and it has the highest impact to change clinical practice. But there's significant threats to randomized controlled trials. Clearly, they're difficult to run. They take a long time. It's a tremendous effort in terms of study design and coordination. They take forever. In the US, we definitely have this phenomenon called study site fatigue, where the sites get really, eventually slow in enrollment and accrual, especially when the trials go beyond 2 or 3 years. They're very expensive, especially with limited institutional resources in terms of research teams, and especially the cost of monitoring is really a really difficult obstacle to overcome, especially in America, where our funding is really under threat. But there's other obstacles, there's just the conduct of a trial, all the pieces of the elements that are required to maintain the high quality of those trials, from regulatory compliance, making sure your sites are following SOPs, the quality of your data. You have multiple handoffs of people from the operating room to the electronic entry form. You can have a lot of error. Obviously, the reporting of AEs and SAEs is critical, and monitoring and auditing is really important. So obviously validating that the quality and integrity of your information being entered, source verification is very difficult to accomplish, as you know. And it's really essential, especially for interventional trials, to keep in mind that there's another level of quality assurance that needs to be maintained, which is really being able to account for the variation in the technique, which we know can have a significant impact on outcomes. So we really have to be aware that for randomized controlled trials, but also for all trials, there's really not a formal process to standardize surgical performance. So we have to create it, we have to implement it, and there's multiple ways to do it. I'll review some of the basics. And I want to point out here, this is all the impact of the threats of performing randomized controlled trials in surgery is reflected in this graph here. I had my research fellow essentially looked at all the randomized controlled trials that were published in the field of surgery for 2019, excluding some orthopedics, GYN, neuro, GU, and endocrine. And you can see here the predominance of randomized controlled trials still in Europe, and especially in Asia, who is performing an increasing number of randomized controlled trials. And you can see in North America, a fraction of those trials being conducted, again, for all those reasons that I just listed. So first and foremost, quality assurance in surgical trials is really essential. The design and methodology and reporting of the outcomes is really important. And we cannot just trust the surgeons, telling us verbally, in a self-reported fashion, that they've done the procedure the way we told them to do. We have to have metrics to be able to assess that. We know surgical interventions are increasingly complex. Techniques change, instrumentation changes, the proficiency varies tremendously, and so does the environment. So our viewers, our membership, our surgeons need to really have the assurance that the procedures are performed the way they're supposed to be performed. Okay, and it's really important, especially when they look at the results of those trials and they're thinking about how am I going to implement this technique or this technology. And it's really important because these variations in surgical performance can really overshadow the true efficacy of these methods that are being described. So if you have poor quality assurance processes, it will impact the endorsement by experts, societies, guidelines, and it will especially impact adoption of our members of these new technologies. And I want to give you an example. I mean, this was a very sobering experience when the EAS and SAGES came together to develop our consensus conference on acute diverticulitis 2 years ago. And you can imagine it was a standard process of consensus development. But what we did that was really special is after we generated a set of recommendations for the management of acute diverticulitis, we sent essentially our recommendation online through a survey to the membership of EAS and SAGES. And it was actually over 1,000 votes that we were able to get in a short period of time. And we asked them with each recommendation, do you agree or disagree based on the best level of evidence that we could find? And the second question was, will this recommendation likely change your practice? And that was really a critical component. We asked them yes, no, and whether or not it was already part of their practice. So they had a chance to comment on that. And we did have a very good agreement in terms of the recommendations that were based on level of evidence. But as you can see, we did have some disagreement in terms of the likelihood that the members felt that they would change practice based on these recommendations and based on the evidence. And I want to point out this particular question of laparoscopic lavage, as you know, a very hot topic for Hinchy 3. And the way we put it, we said, based on the evidence, which was high level of evidence, we made a weak recommendation that lavage may be considered by surgeons with the appropriate expertise and the ability to follow patients closely. And we were balancing the risk of early complication versus the lower stoma rate. And when we asked them online, you can see that the vast majority, 80%, which met our criteria for acceptance, said yes, we agree with the recommendation based on the high level of evidence. But will this recommendation change your practice? You can see we did not get 70% agreement. And so when we presented this data at the meetings, and we actually had the residents describe the trials, obviously all the European trials that are supporting this recommendation, and we reviewed also the 2 meta-analysis, including by Marta Peña, this in publication in 2017. You can see that after that, we asked them to vote again. They continued to agree to 80% with the recommendation, and this time we were able to get consensus. We actually were able to achieve 80% consensus with the recommendation. But this is again to show you the point that although the evidence level was very high because of these level 1 evidence and these randomized controlled trials, there were some issues with the methodology and the way the trial results were reported that caused some discomfort. There was definitely issues with the standardization of laparoscopic lavage, There was some question about the expertise required to perform the lavage, how to perform the lavage, and the experience was lacking. And if you think about our members looking at those recommendations, although they agree this is high quality evidence, how do you implement this clinically was really a problem. It was a source of weakness, and in a lot of ways will impact your surgeon's ability to safely implement these technologies. So this is really important to keep that in mind. The consort checklist has done a fairly good job doing this. The whole point was for them to try to improve the reporting of quality metrics in trials. And they were obviously focused very heavily on expertise, the issue of eligibility during these trials, and especially standardization of those procedures. As you can see reflected in the most recent version of the consort non-pharmacological trial checklist, they really are asking the trials to consider all these elements, including whether or not surgeons or practitioners are complying with study procedures and with protocols specifically relating to intervention. And again, you can see here in this checklist, more emphasis on the framework for successful implementation. Really being able to validate externally the results of those trials means how do we implement this safely to achieve the same results as found in a trial. So I really love this review that was performed by Natalie Blanco and actually Professor Hanna. That reviewed the literature to see whether or not the surgical trials were complying to these consort NPT criteria. And so they looked at a total of 80 randomized controlled trials in surgery published between 2010 and 2011, specifically looking at how well did those trials incorporate this concept of screening for eligibility, expertise, standardization of procedures, and adherence to procedures. And it was really telling. You could see this is now a 20-year-old study, but you can see here the challenges when they were looking at whether or not those trials incorporated eligibility criteria very clearly. Only 6% really had a formal way of deciding which sites were eligible for participation. Same thing with the surgeons. Only 18% of those trials really went through some measures to decide which surgeons were eligible to enroll patients. Same thing with the standardization of interventions. Only a third had some proper, more formal ways to standardize procedures, including workshops, training videos, proof of the procedure being done the correct way by reviewing videos or photographs. And only a third as well looked at really compliance of the surgeons with the procedure the way it was intended to be performed. So clearly something lacking. I'm a colorectal surgeon. Of course, I'm going to be looking at specifically colorectal trials because, you know, if you're not really understanding these subtle things, you know, you may be fooled into thinking that the level 1 randomized controlled trials should be taken at face value. But if you really dig deeper, you'll see here, as they did, and this again work from Professor Hanna and my good friend Nader Francis, looked at all randomized controlled trials in the field of laparoscopic colorectal surgery. Same thing, looking at whether or not they looked very carefully or implemented QA measures and processes to confirm that these were followed. And they looked specifically at trial entry, standardization of surgical procedures, and monitoring of surgeries. And also very interesting, I think they did definitely a better job than the study shown in 2010. But if you look closely, you'll see, so these are all the trials that you all know about if you do rectal cancer surgery. So every single site did look at credentialing of surgeons. So they definitely put in place some metrics for determining which sites and which surgeons should be participating in trial. But it was really not validated very much and not very consistent and really not based on any significant evidence. And if you look at more recent trials updating this data, you can see the ACOSOG, Alacart, and Rollard trial, which is the robotic versus laparoscopic trial. You can see here they also an effort in having at least minimum case volume, but again, not really validated, not really based on any solid evidence. And this is definitely something that the authors emphasize. It's really, when you can, implement some type of metric for credentialing, try to use evidence-based, for example, learning curve data that we now have available, and then obviously use validated assessment tools to confirm competency in these procedures. When they looked at standardization of surgical procedures, very interesting. You can see every trial made a significant effort in outlining some of the steps that they felt were really important to confirm that a TME, a proper laparoscopic TME, was performed. But again, it was really not consistent across the studies, and some studies utilize live demonstration and actual instructional videos, which is really important, but not all of them did that. If you look at more recent trials, however, you can see the move towards implementing more rigid criteria for lab TME being properly conducted. So clearly, I think we're doing a better job defining those steps. But moving forward, the authors made a really good point that you really need to define the steps of the procedure, also incorporating some acceptable variation, what's acceptable deviation from the technique, what's not acceptable deviation from the technique, and then utilizing any international consensus we have available to be able to refine those steps and make them more rigid. Finally, and most importantly, monitoring the quality of surgeries. Again, you can see here some discrepancies. Only 3 trials used centralized monitoring for review of pathological data. And the classic trial was definitely the best because they actually did incorporate blinded review of specimens. They also incorporated a quality metric, which is really essential. They monitored the resection length as a quality indicator, meaning less than 5 centimeters would trigger an alarm in terms of quality metric being followed. And the authors again identified that this was really an essential step to be confirmed that the procedure is performed with high fidelity to the way it's standardized and meant to be performed. So moving forward, all of you are putting together clinical trials, and it doesn't have to be randomized controlled trials. The same principles apply to phase 1 all the way to phase 3. But it's really important to put quality assurance and quality improvement metrics first and foremost. If you're going to be putting these trials together, explore the feasibility of using a QA process that is based on video review. Obviously, that's the most reliable, useful, replicable way to do it, looking at photographs or videos. Try to break down the key elements of the procedure that are going to be serving as your landmark. And so if you can correlate those steps to clinical outcome, even better, because you can really standardize it and you can use it as a quality indicator and monitor it for QA and QI. The most important thing is once you figure that out is how do you implement it? How do you get your sites to comply? And you have to be quite creative. And now we have lots of resources now in terms of webinars, in terms of electronic forms. We use the box at Mount Sinai. We have surgeons upload their videos and we can review them quickly. So you have to incorporate some of the digital platforms to be able to have a quick, prompt, not so stressful way of uploading the data quickly. And especially for your video assessors, being able to access the videos and be able to perform their review in a blinded fashion is really important. So you have to think about all these things. Now we do have some validated tools for video assessment, and we'll talk more about this, but it's really another important thing is to, as much as possible, using competency assessment tools, especially those that have been already validated. And I can't emphasize enough education. I think my biggest regret in the US is that we don't train our surgical residents in the proper etiquette and SOPs and good clinical practice for clinical trials earlier. I think it would be really important, even in medical school, to start teaching our young residents and young medical students on the principles behind quality assurance in surgical trials, because definitely the entire team, it's a team effort. It's a big group effort to really be savvy and familiar with these research pathways and research initiatives and the process of research. So I want to give kudos to Jaap Bonier and his team, who exactly incorporated all this feedback from all these previous trials. And I think they've done a spectacular job in designing their QA measures. And that's definitely the way of conducting randomized controlled trials these days. So what they did is exactly that. They standardized the steps of TATME. So this is a trial of color 3 TATME versus laparoscopic TME. They standardized the procedure by using a Delphi process among their experts to identify essentially mandatory, optional, and forbidden, so never steps. And then they were able to design a competency assessment tool that they validated at least internally in terms of inter-item and inter-rater of validity. And they were able to use those steps to generate an operative guide. And that's also very helpful for the sites that are essentially conducting the procedure, so they can refer to the site to keep an eye on how they're doing these procedures. And then they have a digital platform to be able to upload the videos. And you can see here, this is a very complex chart, but really quite simple in terms of they broke it down into 9 surgical steps. They have 4 performance qualities: exposure, execution, adverse events, and end product quality. And then they have a score from 1 to 4. Again, very, very smart, very useful, replicable way to use it. And this is exactly what it's all about, because it can be then used by the blinded reviewers to make their rankings and to make their ratings. In the US, we're conducting a phase 2 TME trial. And this is not a randomized trial, but we identified early on that the quality of the TME specimen was essential, because as we all know, it is a quality indicator for surgical performance with significant repercussions in terms of oncologic outcome. So we really wanted to make sure that the specimens were being evaluated in an objective fashion, that it was consistent, and so we really focused on QA measures in that regard. So we did incorporate as well a blinded centralized review of pathological specimens, and I'll show you what it looks like. We had 28 specimens, TME specimens at the beginning. You can see here, obviously we had some issues with the processing of the TME specimen, and 4 major discordances between the site readings and blood and pathological review. And by major discordance, I mean specimen is read as complete by the site, but then the blinded review returns a reading of incomplete based on photographs. That's a problem. So you can see here the way we handled it was this immediately triggered a consensus meeting essentially between the site pathologist and the blinded pathologist, who were able to review the specimens and come to an agreement based on the review of the specimen. And that's really important, as well as another metric, which is, once you have a reading of incomplete that is confirmed and agreed upon after this feedback review, is it immediately triggers a video review by 2 blinded experts to review the procedure in detail to see and evaluate what went wrong. How did the procedure result in this outcome, and what is the feedback to the surgeon? Another metric is obviously safety monitoring metric for the data safety committee. It's obviously setting some threshold in which where you have 2 or more incomplete specimens and or positive margins, the site gets put on hold pending further review. So you not only have to have a quality assurance mechanism, but you also have to have obviously an initiative, an action plan outlined on how you're going to deal with this, how you're going to retrain the site or retrain the pathologist. Whatever your corrective action plan needs to be clearly stated and emphasized in your publication as well. This is what the impact of our feedback mechanism and QA has been. You can see here we had a significant decrease in the rate of underscored or overscored rating by the site pathologist. In response to the feedback, you can see a much better concordance in the reading between the site pathologist and the blinded pathologist, again showing that the sites are getting better over time. It's not just a learning curve, it's beyond the learning curve. It really is the fact that they're paying much more attention and really implementing these rigid criteria, knowing that they're being monitored. So just to end, I just want to kind of touch upon the next new challenges that are coming our way when it comes to, like if we didn't have enough challenges as it is, to continue performing high quality clinical trials in surgery. But you have to be aware that we're going to be having an onslaught of new technologies in terms of robotics, and the luminal hybrid technologies are coming, and they're coming hard. And so we're going to have to really pull together to figure out how we're going to continue enforcing the quality assurance of those trials, because it's going to be very important to be able to return high quality papers on demonstrating the safety and efficacy of these procedures, especially relative to other procedures. We have digital platforms being incorporated that we're going to have to study, AI augmented interface for all those technologies. So a lot of novel research questions are going to come along beyond safety, efficacy, and oncologic outcomes. Many questions are going to have to be evaluated, such as the impact on patient and patient quality of life, prompts, efficiency, costs, and sustainability. All these questions that we're just starting to think about are going to become increasingly important. So when you think about designing your trials and quality metrics to follow these are going to be very important to think about. The research funding is a disaster. I know Europe has its own issues, but I can tell you in the US, we're increasingly concerned in terms of national federal funding is under threat. And so we have to move towards more hybrid funding models. And by hybrid, I mean the combination of foundation, industry, somehow, fundraising by our patients, our grateful patients, and groups and patient representative groups, and potentially crowdfunding. So we're going to have to start to really think outside the box on how we put these international trials together. And we have to utilize the power of digital platforms. Remote monitoring is going to be increasingly important because it is so expensive. You have to find creative ways to avoid site visits and to be able to do it all remotely. And there's definitely a lot of options that are emerging that should facilitate this. There's clearly a huge appeal in conducting international surgical trials. You increase the diversity of your research subject, and that's something that's been under a lot of criticism, that a lot of clinical trials, especially in drug therapies, have really come from a very homogeneous group of patients, and so with implications that are hard to assess for other populations. So clearly we're diversifying our research subject pool. This brings a tremendous amount of opportunity, but also a tremendous amount of challenge in terms of how do you coordinate it, the cost of these large international trials. And so there's a lot to learn and a lot to think about. But clearly a big question that's emerging is, can you supplement or replace randomized controlled trials with these large data, big data international registries? Could you potentially essentially eliminate the biases in treatment by having a large sample pool? And that's something I'm sure up for debate in our discussion. So what does the future hold? Again, big data is coming. Automated systematic data extraction, that's something I'm very interested in. Is can we access each other's sites? We're starting to do this in the US through these electronic platforms, obviously following HIPAA regulations, but you can essentially have access to the electronic data files and be able to extract data yourself, as opposed to having to go on site and do it. You can do this remotely. There's also this connected operating rooms concept where you can actually record a lot of information about what's happening in the operating room, like black box, I'll show you in a minute, that essentially can collect data that you can use eventually to correlate to outcomes and see whether or not these could serve as quality measures. And then finally, AI-powered quality indicator assessments. So video-based competency assessment is moving to the digital world. There's no question that AI-powered algorithms are starting to come along very nicely and will potentially be very helpful for assessment of quality in our surgical trials. So this is an example of the black box. As I said, you have these cameras that are recording every aspect of an operation, things that you're not even aware of. And putting all these data together can potentially result in some very interesting assessment of surgical team performance, not just individual surgeon performance. And this data can be extremely helpful and can be fed back to the sites. And so you can think how this data could be very helpful for quality assessment and improvement for surgical trials as well. And finally, this AI-powered platform that I talked about, this is one example, and there's many more coming. But this one uses AI-based indexing to essentially, in literally 20 minutes, to review a 2.5 to 3 hour operation by breaking down to some key steps, like we talked about. This is a right colectomy, so you talk about, mesocolic excision, dissection, your ileocolic pedicle identification, and then eventually your anastomosis. So if you can use these algorithms to very quickly go through videos, you can imagine the wealth of data that can be analyzed very quickly. This will help save some cost in terms of consulting, reviews of lengthy videos and all this kind of thing. So these could be very nicely incorporated in surgical trial methodology and quality assurance processes to make it much easier to do this on a global scale. And I'll stop there. Thank you very much.
Dr. Sylla, thank you much for a fantastic discussion and talk. Got some questions from the audience. First question is, how do you think we balance the implementation of a high quality SQA program within an RCT against potentially reducing the external validity of that trial when applying the technique internationally by the average surgeon in an average hospital?
That's exactly. I mean, implementation is the big issue. I mean, what is the purpose or the point of the trial if you can't have effective measures of ensuring that it's applicable? I think one way to overcoming it again is if you design your trial with more diverse sites. So I think that's been something that we've been very interested in. Is of course you have to have the qualifying trial entry in terms of expertise and volume, but really making sure that you have sites that represent various areas in the country, various types of practices, various types of practitioners, and especially various types of patients, I think is going to increase the validity of these trials, because you're going to be able to show that you have consistent results across a large cohort of, sometimes disparate surgeons and practices. I think this will really confirm and at least alleviate the concern that these procedures are not going to be applicable to the wider audience. So I think that's the strategy, and that's why I'm excited about this global type of trials where you can really see that if you follow a certain recipe in China, you can have the same results as you're having in Denmark. I think this is going to be the power of external validation.
Great. And another question from the audience. How do we balance the need for careful quality control in surgical trials and the checks and balances to make sure standards are high enough with the need to convince surgeons to sign up to participate?
That's an excellent question. And believe me, this is what I struggle with the most. I mean, I can't tell you how many sites, who have this great reputation and, are going to have, a high volume and, but when you describe to them the SOPs and what's going to be required and the quality metrics and how they're going to be scrutinized and how they have to upload all their videos, and, then you get some pushback. And I think, and Jaap can comment on this, obviously, because he's been doing this at a much larger scale. But even within our trials, the TATME trial of 12 sites, it's been a struggle, and I think part of it is a culture. I think you have to have a culture of believing in quality assurance and believing in these processes. And I think in the US, that culture has been under threat. Part of it is, you know, the big push to generate money and taking away, you know, the opportunities to conduct research. We've definitely had a big blow in damage to that culture. I think in Europe, you're far ahead. There's a tremendous culture of academia and really believing in these processes, much stronger than it is in the US, I hate to say. But I think we're trying to recapture this, and especially I'm excited again about international trials because we're recapturing the spirit of we can do better. And yes, the process is very, very painful. You know, checks and balances are important. There's a reason why we have them. But, you know, being in part of a big international trial has tremendous advantages, and we're trying to cultivate that back in the US and get people excited again to enter those big trials. So don't leave us out. We know we're part of several international collaboratives, and my plea is to continue these efforts because it's really to the benefit of all our patients, and that's important.
We have a question from our own Professor Hannah. He asks you, what are the biggest challenges to implement quality assurance in RCTs?
The biggest, I mean, that comes back to the other question. The biggest challenges I really think is the culture. Because you can have the most sophisticated, you know, design and measures and process and SOP, and you've outlined every step, but you got to get buy-in by the sites. And, you know, it's unfortunately volume doesn't equal quality, right? It's not because a site does the most cases that they're the best in terms of quality assurance metrics. As a matter of fact, I find sometimes it's quite the opposite. And, you know, you have some sites and some surgeons who are quite arrogant, I hate to say, but really do not like the process of being told how to do what they do. And so, you know, it is a humbling process to subject yourself and your site to a quality measure, to you know, a review, to a site visit, and again, it comes back to culture. So I give credit to a lot of department chairs who've kept that culture going and encouraged the faculty to join these trials, because I think, you know, and that's the big point, is the quality improvement that you get within the context of the trial is absolutely translatable to outside of the trial. You find that you change a culture, you change the method, you change the thinking. But again, to answer the question specifically, I think it's the culture, it's the willingness, it's the humility to accept that you can get better.
Dr. Sylla, I have to thank you on behalf of our audience for joining us from New York and for a fantastic talk. Thank you very much indeed.
My pleasure. It was a pleasure.
Thank you. Without further ado, I think for the sake of time, we'll proceed on to our next talk, and then we'll have a short break after that. So I'd like to introduce Mr. Simon Paterson-Brown, an old friend of St. Mary's who went to medical school here as well. And today he's going to give the Dudley Memorial Lecture on surgical training in a stressful environment. Over to you, Simon. Thank you very much indeed.
Okay, well, thank you very much. I've shared my screen.
Yep, it's all working.
I can't see it. So can you share the screen, Benji?
Your screen is shared.
I can't see it.
It's shared for everyone else. Can you
Is it?
Slides?
Well, let me see if I can see it. There we go. You can all see that, I hope.
Yes.
Well, thank you very much, Ahmed. It's a great privilege and, of course, a pleasure to give the 9th Professor Hugh Dudley Memorial Lecture. I've been asked to talk on surgical training in a stressful environment, but I have to say surgery is stressful, and anybody who has trained or is training knows that we work in a stressful environment, whether or not it's with COVID, conflict, and various other problems. So I'm just going to talk about surgery and stress and put those things together. And this is a pretty stressful encounter. This is me on the right here as an SHO, Senior House Officer, being trained by Hugh Dudley, and I'm carrying out my first thyroidectomy. A senior house officer nowadays would be a core trainee 1 or maybe 2. So quite early in the training program, I was taking part in a difficult operation. But my connections with Hugh Dudley actually go back a little bit further. On the right here is my grandfather, Keith Paterson-Brown, who taught Hugh Dudley how to do thyroidectomies in the Royal Infirmary of Edinburgh. And at that time, Hugh Dudley was a lecturer, or in those days, a senior registrar with Professor Sir James Lermonth, whose comment on Hugh Dudley was that he was a young man in a hurry. And I think everybody who worked with him would acknowledge that was a fairly good statement. Here's a picture from January 1948, and on the right in the front row is Hugh Dudley as a lecturer, registrar, and you can see here at that time he had a short sleeved white coat, which he continued to wear throughout his career. And actually there were a few other surgeons in Edinburgh at that time, here and here, who were also wearing white coats, clearly well before their time. Well, my links with Hugh Dudley and at St Mary's go back a long time. Here is the research group that we had at St Mary's. My 2 NHS consultants who I worked with, Geoffrey Glazer, seen here enjoying the sun in Nice, where we went down with our wives to visit a hospital in Nice at the early stages of developing laparoscopic surgery. David Rosen, the other half of the Glazer-Rosen firm. My old friend Brian Parry, who was the senior registrar in the academic unit when I was the senior house officer, and he went back to Auckland in New Zealand as the professor. He's now retired. And the late and very sorely missed Brian Ellis, who was the other senior registrar at St Mary's at that time, who went on to become a consultant in Ashford in Middlesex and was an excellent surgeon and a really good trainer. And I went to work for him as a registrar. And of course, not to forget Professor Avril Mansfield, who got a wonderful trophy and award last year as one of the NHS heroes. So these are the connections that came directly from Hugh Dudley, linking me to them. And a similar link came in because I went out on Hugh Dudley's recommendations to work with Arthur Lee in Hong Kong as a fellow. And while I was out there, I met Sir David Carter, who was a professor of surgery in Edinburgh, who asked me to come back as a visiting lecturer for a year, where I met my long-term colleague and great friend James Garden, and subsequently I was appointed in Edinburgh as a consultant. So I'm not going to talk to you today about your surgical expertise, whether it be laparoscopic, whether it be open. These techniques can all be trained in difficult situations outside the operating theatre. We need to use simulators more, open simulator, laparoscopic box trainer, and now the computer programs that we have and that we've heard about earlier on. Any trainer can train you to operate, but it's the decision making and the behaviors around the operating room which will convert an average surgeon into a good surgeon into a better surgeon. And we're going to look at this stressful environment here. There are internal issues that we bring to work every day, whether we're surgeons or physicians or radiologists or whatever else. We have personal issues. We have our experience and our knowledge, how good we are at what we are doing at that time. And obviously trainees are less good and less experienced, we hope, than the consultant trainers. We're learning all the time as to what is going on, and we learn from the moment we start working to when we retire. And we have our physiological stressful internal environment, tiredness, hungry, perhaps medical issues, and they will all affect how we perform surgically. We have the external pressures, the team structure, the support we have, and our relationships within the team, and I'm going to talk a little bit about that in a moment. And then we've got our performance, the technical performance, and I've already said anybody can improve their performance by getting onto the simulators and not learning directly in patients. You should know how to laparoscopically suture before you come to theatre, rather than try it as a first or second time in a patient. Our clinical knowledge we should work on all the time. And then now what I'm going to talk about a bit more is our non-technical skills, which we didn't know much about when I was in training, but we do know a bit more now. And these come within the specialty of human factors and ergonomics. This is a specialty in its own right. You go to university and you study it for 3 or 4 years and you get a degree. And it involves the behaviors, attitudes, organization, the equipment we work with, our working environment, the systems we have to improve our output and our safety in all high technology and high performing industries. They have human factors experts helping them. Sadly, we don't have enough of them in the health service. Our non-technical skills, how we interlink with other people, and our human performance limitation, recognizing tiredness, recognizing the stresses we are under and what we're going to deal with a little bit more now, and all put together how we act as a team in order to improve performance and patient outcomes. Some of this work we took out into the community in Scotland many years ago with the late Pamela Baldwin, a psychologist in Edinburgh, very sadly taken before her time. And we asked surgeons in Edinburgh what they in the southeast of Scotland, what they thought the skills were required for being a good surgeon. And you can see here that technical was only a small percentage of the actual skills thought to be required to be a good consultant surgeon. And this led directly onto a project that we ran between the Royal College of Surgeons of Edinburgh and the School of Psychology in Aberdeen University under the supervision of Professor Rona Flynn, who actually gave the first Hugh Dudley Memorial Lecture. And it was funded by the College of Surgeons of Edinburgh and NHS Education for Scotland, NES. Our postdoctoral research fellow was Steve Yule, who picked up this project. And here he is, this was in 2002, and here he is at the beginning of this year, having just obtained the chair of behavioural sciences at Edinburgh University within the School of Surgery. And this project was aimed at identifying the non-technical skills required to support good technical surgery. And what I said before, these are the skills that make an average surgeon better and a good surgeon excellent. And he came up with this taxonomy. Steve came up with this taxonomy. The 2 cognitive categories, situation awareness, knowing what's going on around you in the operating theatre, understanding the information, and then anticipating what might happen in the future so that you can make an appropriate and sensible decision on the management at that time. And this is iterative and it continues throughout an operation. It's equally important on ward rounds and assessing patients in an emergency department. But here we're talking about it in the operating theatre. And then we've got our 2 social categories, our communication and teamwork, how we work, exchange information and coordinate the teamwork within the team. And then our leadership characteristics in helping the team work, supporting others and coping with pressure. And in this scenario for this talk, we're of course talking about stress. And this taxonomy we've got here, the NOTS taxonomy, there's one for anaesthetic, scrub practitioners, scrub nurses, and the anaesthetic assistants. And this is where NOTS has been worked on around the world, and courses are being run, and the NOTS taxonomy is being used. So wide dissemination of this process. So let's take it a little bit further and look about stress and how we perform in stress and how our surgical trainees will perform in under stressful situations and how the trainer perhaps responds. Here's our patient, and there's lots and lots of people in the operating room, all focused, we hope, on the patient. And increasingly, we have the equipment within the operating theatre, maybe in the endoscopy room, that we have to use in order to carry out our operation. Here is a colleague of mine undertaking a liver excision before liver transplantation for fulminant hepatic failure. Now, this surgeon has no idea what is going on anywhere except in the deep dark hole where he's removing the liver. And he relies entirely on good communication and teamwork so that he and the anaesthetist, the scrub nurse, the perfusionist, all know what's happening throughout the operation in order to improve performance. So here you might be in the operating theatre, the consultant trainer, the trainee, and there's lots of things going on in your head, increasing the pressure and the stress you may have in carrying out perhaps a simple operation for the trainer, but perhaps difficult for the trainee, or an operation that's beginning to go wrong. So we look at our mental model. What is going on in my head, the surgeon's head, the anaesthetist's head, and the scrub nurse's head? And do we all have the same mental model? Do we have a shared mental model during the operation so that we all know what's happening and we all anticipate what we might need in the future and can start organizing those things? This is too common a diagram that I think that occurs in a training operation. The consultant has one mental model and the trainee a completely different mental model. And as a result, they go down different pathways. And it is only by a good shared mental model, communication and discussion, that we can have the same interpretation and go down the same route. And this brings us to a little bit of psychology. Now, I'm not a psychologist, but a little bit of psychobabble helps from time to time. Here we have our working memory. It's limited. There's a limited amount of things that can go on within your head at any one time, what you might call our RAM. And this is what we use to make decisions, to assess a situation, to decide what we're going to do in either making a diagnosis, deciding to operate, or during an operation. And here is our long-term memory, which we've built up over many, many years of hard work, teaching, training, reading, and so on. And we can access this, but it takes a little bit of time to access it. And the more you are within an operation, the less likely you are to be able to access this unless you can stop and think about other procedures, protocols, and so on. And into this, we are stressed. The trainee's stressed because they don't know how to do the operation, or it's a complex operation. They haven't done it before. They've read about it perhaps, or they've only done one or two. The trainer might be stressed because the trainer perhaps has other things to do. The list's going slowly. And in this particular problem of COVID, there's an issue about trying to get as much operating done as possible. And these will cause stress within both the trainer and the trainee. We have distractions in the operating theatre, the phone's going off, bleeps, people coming in and out. We might be fatigued. We might have been up the night before. We might have had a poor handover. We might not know as much about the patient as we should, particularly in the emergency situation. The workload may be a lot. The equipment may not be working well. And we may be hungry. It may have been a long operation. We may be thirsty. And we add into this additional stress, which we can pick up from what's happening at the moment. Environmental factors, COVID-19 for all of us, but operating in conflict areas around the world. And there's many areas where the safety of the patient and the safety of the surgical team are really in trouble. We have the weather. For example, I go and work from time to time in remote hospitals in Scotland, where we have trouble transferring patients out from small hospitals to bigger hospitals because the helicopter or the fixed wing aircraft can't fly. That produces more stress for the surgical team. And we have ongoing problems with undermining behavior within the hospitals in all specialties, which should lead independently to increased stress levels. And what this does is this shrinks our working memory, our RAM. This stops us being able to make decisions, to think, to make judgments. And when that occurs, we have difficulty in making decisions. We may freeze, and this is why a trainee under stress may not be able to decide what to do when the operation starts to become more difficult, and will rely on the trainer to help them. It's not that they don't know things, but they can't access them. The long-term memory can't be accessed, but it's because other things, the stress is filling up this working memory. So this reduces our thinking space. It interferes with our ability to think, our cognition, our situation awareness, understanding what's happening around us is deteriorated, and therefore we can't make some decisions. It reduces our ability to communicate with the team, and it affects our leadership ability when we're trying to get the job done and focus on teamwork. We know that high-performing teams have strong leadership. They hold strong and shared mental models that I showed you earlier with that Venn diagram. They have clear roles and responsibilities. And remember, in an operating theatre and a list of patients, you may change who's the surgeon and who's the assistant during the course of the day. And it's important that we all know that and understand how things may change over. We need to evolve cooperation and display backup behaviours. When there's stress in theatre, we need to share the workload with our colleagues, perhaps bring other colleagues into theatre in difficult cases, so that our green box can be expanded a little bit and the person carrying out an operation can make decisions and carry on. And that's why in major trauma, the surgeon or the organizer for the trauma often doesn't take part in anything but stands back and organizes the surgical team. And what we need to do is we need to evaluate our team performance. Teams should regularly meet together. They should socialize together. And in some cases, perhaps once or twice a year, have a social event. Difficult at the minute with our social distancing, but it is something that really does engender good team spirit. We know from multiple studies that teamwork is positively correlated with performance. If you've got a good team and the team works well together, then you have a much higher outcome in patient satisfaction, audit figures, complications, and even mortality. The Royal College of Surgeons of England recently undertook a report of 100 surgical units over 10 years. Poor teamwork was identified in 76% of these reviews. There was various other problems within there relating to teamwork and behaviours, but it's teamwork that results in poor unit outcomes. We've got a lot of opportunities day to day as to how we can improve our teamwork. We can have daily briefing at the beginning of the day, whether it's before you start your ward round, whether it's before you do your post-receiving round if you're on the emergency team, whether it's in theatre before you start your operating list for the day. We know there are good checklists before we start every operation, and that should be clear and involve the whole team, so everybody knows what is going to happen for each patient. If I have an operation, I want to make sure that every single person is involved in my checklist. We need to debrief after each procedure, make sure that we're happy that we did everything correctly. And we also need to debrief at the end of each day so that we know how things went that day, whether it be your emergency team and your ward rounds, or whether it be the operating theatre. And if things didn't go as well as they could have gone, then we can work out how we deal with it. We need to talk to colleagues and remember it's the whole team who are important here, and we must share the workload within the team. And remember, of course, that the patient is at the centre of our work. So this all revolves around better communication. If you're interested in team training and improving the team, the Royal College of Surgeons of Edinburgh has developed with Craig McElhenney, who's a urologist in Larbert near Stirling, George Youngston, who's a retired paediatric surgeon in Aberdeen, and Nicky Moran, who's an anaesthetist in Edinburgh, this team training, safety in numbers team training, SAINT, which is undertaken in individual hospitals amongst the whole team, the theatre team, so anaesthetists, surgeons, nurses, ODPs, perfusionists, and so on. So I'm going to finish up. Surgical training in a stressful environment. Well, surgery is stressful, and our environments are always stressful, irrespective of what is happening now, what happened in the past, and what's happening in the future. But I think the most important thing about dealing with this is to try very hard to develop a well-functioning team, where you have support from trainers and colleagues, and recognise that this all takes time. An operation for training will take longer than an operation carried out by the trainer. But the point about the whole thing is that it will involve the team. And if you're willing to put time into it, the trainer will enjoy it, the trainee will get more out of it, and the whole surgical team will perform better. And remember, We've heard a little bit today about improving our technical ability, but surgical training is not all about technical ability and operating. It's about those other factors which make you as a good surgeon into a better surgeon, or an average surgeon into a good surgeon. So thank you very much. It's been a great honour and privilege to give the 9th Hugh Dudley Memorial Lecture. If you're interested in what I've talked about, you can go to the Royal College of Surgeons of Edinburgh website, and when you're allowed to travel, perhaps next year, you can visit the 3 bridges that go from the south of Edinburgh across into the northern parts, and if you're lucky, you might even be able to see the Northern Lights. So thank you very much.
Simon, thank you very much for a superb and fantastic and engaging lecture. Very kind of you. We've got some questions. First of all, I'd like to ask you, music in the operating room. Now, does that reduce stress, or does that hamper and act as an obstacle to communication between members of the surgical team?
Well, that's a very good question, Ahmed, and that will depend on 2 things. Firstly, what sort of music it is. And of course, many people in the operating theatre have different choices. So what Ara Darzi chooses for his music may be very different than what I choose or the anaesthetist chooses. And of course, if you choose the wrong music, you maybe upset the wrong person. But the answer is music in general is distracting. And if it's loud, it distracts more. In straightforward operations, a lot of surgeons and anaesthetists quite like quiet background music. It sort of stops the silence in theatre, which can be stressful in itself. So I think quiet music is perfectly reasonable. But when the operation becomes difficult and stressful, my suggestions would be you turn the music off, everybody concentrates, you get past that difficult bit, things settle down, and then you can put the music back on again. So a good choice of music, and keep the volume low.
Brilliant, good answer. Another question we have is, many of us feel comfortable teaching the technical skills, but there are trainees where we struggle to teach the situational awareness and communication skills. Do you think that these non-technical skills can be taught to everyone, even in 2020? And can some surgeons be resistant to being taught these skills?
Yeah, I mean, that's another good question, Ahmed. The issues around all these skills can be taught. We can't change a surgeon's personality, a trainee's personality, but we can teach them how to behave professionally within the operating theatre or within the hospital. So yes, we can teach them, and all these skills are now required by the GMC. The new curricula coming out by the GMC require good communication, teamwork, good understanding of how human factors integrates in healthcare. And many regions, and England, you are ahead of us in Scotland. Many English regions, I don't know if you call them deaneries or HEEs or whatever you call them in England, are now giving non-technical skills, so NOTS courses, to all their surgical trainees in about ST 4 or 5. So I think these are essential skills which my generation were never taught, and I think they should be taught. Some people are good at them more naturally than others, but I think if we understand what they are, then we can take things forward. So the answer is yes, we should be teaching them. The difficulty is that a lot of trainers don't really know them because they weren't taught them. So it's up to us to get out there and educate the surgical community.
We have another question on a similar sort of theme, which is, how do you think we can optimize applying these principles in training with the increasing erosion of surgical firms?
Yeah, I mean, that's another good. They're all good questions because they are so relevant. Surgical firms have gone really, and what we're now talking about is much bigger surgical teams. And I think it is difficult to have the relationship that you might have over 6 months where you have one registrar working with you, or 2 registrars and 2 housemen. And now you might have 6 or 8 trainees, and you might have 12 FYs. And it's very difficult. And I think what we try and do now is you try and get the team together for a week at a time. So you're on call week, your theatre week, your whatever. perhaps even on a daily basis. You meet at the beginning of the day, you learn who you're working with, and we often work with new foundation doctors every day because they rotate. So you know who you're working with at the beginning of the day, you understand where they are in their training levels. You might do a ward round with them, you might go to theatre with them, you have a cup of coffee, you chat. So it's using teamwork to the ultimate when you actually learn who your team is at the beginning of every day. You've got to remember that the airline crews, the cockpit crews, and the hostesses and the pilot, the co-pilot and so on, they meet for the first time before they fly in most of the airlines. They don't know each other, so they have to use teamwork skills, which we've talked about here and what we talk about in the NOTS course, so that they can work closely as a team, having never met each other before. I know it's difficult in surgery when there's other things you need, but I think we have to use those teamwork skills to help us.
Great, thank you. I'm just going to check with our fellow faculty panelists if anybody else has a question for you. No, I think that's it. Simon, thank you very much indeed for a fantastic talk. And now what I propose we do is we take a quick 8 or 9 minute break until 4:40 when we'll have the award-winning poster presentation. So ladies and gentlemen, I'll ask Benji now to put forward some of the winning posters. You'll see there's be a slideshow on that will come up now, and we'll run that till about 4:40. And then at that stage, we'll have the winning poster presentation.
You can see that now, can you?
Yes, thank you very much. Yeah.
Okay.
Great. So we've reached 4:40. At this stage, Benji, I'd like to invite the winning poster presenter, Alex Davichok. Many congratulations. Your poster was judged by some of the harshest judges in London, and I'm pleased to inform you, you got the top marks. So many congratulations. The floor is yours. You have about 7 minutes to present your poster, and hopefully we'll have some tough questions for you to follow. I think you're on mute.
Thank you so much. It's a great honor. So I'll use my slides just to make it a bit more visual. Can you see the slides?
Yes, they're live.
And do they advance?
Yes.
Yes, great. Thank you so much. My name is Alex. I'm a fifth-year medical student here at Imperial, and I have a pleasure to present a study conducted by the neuroergonomics research team here at Imperial on improving surgical performance using transcranial electrical stimulation. So why do we actually focus on improving surgical performance? There is emerging database showing that surgical skills are directly related to patient outcomes. Both these studies on bariatric surgery and cancer surgery outcomes clearly show that lower surgeon skill means worse patient outcomes. And with the limited training time we have now for our surgical trainees, it's essential that we pursue other ways of improving surgical performance. One possible way of doing that is exploring transcranial electrical stimulation. In our research, we're using modality called transcranial direct current stimulation, TDCS for short. In this technique, we use these sponge pads with rubber electrodes fitted inside them to deliver a small direct electrical current to particular brain areas we want to target. This small current can excite neurons and hence increase activation in these particular brain areas. And when we are thinking about surgical tasks, we're focusing on prefrontal cortex, which is brain area responsible for executive function, attention, and memory. So is there any evidence available to support the use of this technique in surgery at all? Actually, yes, and it's emerging quite quickly. So these are two studies from the Canadian group led by Chehansky, which show improvement with active TDCS in surgical performance in simulated neurosurgical task and laparoscopic task, respectively, as compared to sham stimulation. The laparoscopic findings were recently corroborated by a study by Cox et al. In 2020. Also, our own study using a simple surgical task, which we conducted this year, and it's exactly the same task I'm going to show you was used for this study, showed that active TDCS improves outcomes better in comparison to sham stimulation. So the neuroergonomics group at Imperial for almost past 15 years have been trying to understand the brain activation patterns which arise when surgeons or trainees are learning how to perform particular procedures. And over that time, they concluded that FNIRS, so functional near-infrared spectroscopy, is a safe and effective technique to do that. And when a surgeon or trainee is performing a task, the brain activation curve looks somehow like that. So at the beginning of the task, it goes up and then falls down. Recently, we also conducted a systematic review of combining these two methodologies, so functional near-infrared spectroscopy and transcranial direct current stimulation studies. And what we found is that when we are monitoring brain activation during a task with some concurrently applied neurostimulation, brain activation is somehow attenuated. However, the mechanisms behind that augmentation of performance and these changes in hemodynamic patterns are not really clear. And our systematic review also found that there were no studies which would combine these two methodology and apply them on a surgical task. So that's how we arrived at the aim of this study. So we wanted to investigate concurrent application of TDCS and FNIRS during a surgical task to get a better understanding of the physiology of impact of neurostimulation on surgical skills acquisition. And it's the first pilot study of this kind. So the first barrier we had to overcome was combining the two setups, since at the time there was no commercially available option for that. So what we did, we took the standard TDCS electrode pads and we adjusted them so that we could house FNIRS optodes within them. So we used a concurrent montage and fitted that within an FNIRS cap and fitted on participant's head. We also fitted through these FNIRS optodes, and that's quite special, and that's really rare thing in these study designs, because with our model we can monitor brain function and stimulate at the same cortical area. And there are only a couple other studies which could do that. There are two types of FNIRS optodes. First one is FNIRS emitter, which emits near-infrared light, which goes through the cortex area monitored. And then there are FNIRS detectors, which pick up this light. And we can see these FNIRS channels arise, which can be then used to monitor the changes in the concentration of hemoglobin species in that particular cortical area. And this is a proxy measure for getting brain activation. For our study, we used a simple surgical task. We asked the participants to make 3-throw hand knots on the demarcated 5mm wide areas. And we assessed their performance using the time taken. And we also used this validated knot quality score to calculate it. So we had a single session for this pilot study. We invited 6 medical students with some prior knot tying experience, but we gave them a bit of time to practice. And then before they were involved in the study, they were assessed by an experienced surgeon. We wanted to eliminate the risk of bias from the learning effect during the study. The study was composed of 3 blocks, identical ones, each of 15 minutes, where participants were asked to do 9 repetitions of the task. The first one was pre-stimulation. The second one was during the stimulation with 2 milliamperes bilateral prefrontal cortex stimulation applied. And the third one was post-stimulation. And throughout the whole experiment, we're monitoring brain activation using FNIRS. So let's have a look at some results. So these boxes are the FNIRS channels I mentioned at the beginning. And if they are red in this figure, that means they are activated, meaning there is increase in concentration of oxygenated hemoglobin and a coupled decrease in concentration of deoxygenated hemoglobin. And in here you can see that when the participants were performing the task before stimulation, there is quite a lot of activation. In here we applied TDCS and it looks quite similar. However, the activation reduced from 17 to 15 active channels. But in here you can see quite a widespread attenuation, so only 6 channels left. When we think about different metric of these hemodynamic changes, which is change in concentration of oxygenated hemoglobin, you can see that before it's quite mixed with red boxes meaning increase in hemoglobin concentration, blue ones on decrease. But then you can see the attenuation in hemoglobin concentration quite clearly during TDCS application and post as well. Black outlines signify the statistically significant channels. And this attenuation confirmed our findings from the systematic review. When it comes to the task performance, median performance improved with TDCS stimulation. However, it was a small study of 6 participants and the results were insignificant. So when it comes to conclusions, our study found that neurostimulation reduced prefrontal cortex engagement while performing surgical task. And our previous studies found that neurostimulation improved task performance. And these could be potentially explained by increasing neural efficiency and better allocation of brain resources while brain is stimulated with TDCS. However, these are very early pilot findings, and we need a robust randomized controlled trial to support that with data, and this is already planned. Thank you so much for your time and for giving me this opportunity to present at the LSS this year. Thank you so much.
Alex, many congratulations. I mean, for a medical student, this is a fantastic work you've done, so I'll be very impressed. I'm sure you'll be happy to accept some questions. First of all, I'd like to ask you, are there any plans to extrapolate these techniques sort of away from, a lab-based skills to actually use in the real sort of human situation in a operating room?
Thank you for the question. So let me answer it in 2 points. So the first one would be that we are, as the research group, neuroergonomics team is exploring use of TDCS, so stimulation in multiple surgical procedures, so from open to laparoscopic to even robotic, and the papers are coming out on that. When it comes to FNIRS, also for past 15 years, it was used in the lab settings on a variety of different surgical tasks. However, before it could be implemented safely and concurrently in the operating theater, there needs to be a large randomized controlled trial in the lab setting. and only once the results are confirmed and the whole process is validated, then we could try and employ that in the real life situation. However, in different other professions like aircraft pilots or vehicle operators, there were attempts to use this in real field research.
Great, thank you very much. I'm just checking on the system if there's any other questions. Any questions from the panelists? All right, Alex, I think you're being led off. So again, many congratulations to you for winning the first prize. I should also take this opportunity to mention that the runner-up prize was won by Abhishek Srivastava. So congratulations to Abhishek for the runner-up prize. At this stage, it just suffices for me to basically say a huge thank you to the team at Imperial. In particular, I'd like to thank Wendy, Torto, and Bonjer, of course, who's been working non-stop with the rest of the team to make this event possible. I have to say, on reflection, probably a live event is easier for most of us because we're used to it. Also, big thanks to Tony Tarragona-Fiol and to Adrian Manel as well. And lastly, thanks to Chris Peters, Amanda Cross, and Shiraz Walker for also helping me with coming up with the ideas and the concepts for today. Now, normally at this stage, Professor Hannah and I would invite you all to join us for drinks and dinner at the Rector's Lodge in Queensgate, number 170 Queensgate. But unfortunately, this year we cannot do that. So as we say, let's take a rain check, and hopefully we can welcome you in person next year for drinks and dinner. So apologies for that. At this stage, I will now pass on the mic to Professor Hannah for closing remarks. Thank you very much.
Thanks, Ahmed, for your work, and it turns to be harder than face-to-face meeting. I believe that. So thank you for putting everything together, you and Bonjer and Wendy. So it's really an enjoyable evening, which continues to be enjoyable symposium. So the first time this was Prof. Darzi said 2004, I think. I would just join the department, or 6, I would just join the department when Prof. Darzi established this symposium, and really it's a very enjoyable experience. And it is a very good thing to see everybody contributing, all the PhD students, and the winner is a medical student, which is very nice to see. So the theme actually is very nicely put together. Jaap talked about training and surgical skills and how to train in the era of digital and media, and his Amsterdam Center is a credit and witness to his thoughts and his leadership, and it's very nice to enjoy your talk, and looking forward to see the slides as you promised with a record to be available. Patricia Sylla take this forward and looked at how to implement it in a context of clinical trial, which is very challenging thing to do, and really that's what's needed, so we can have our clinical trials really applicable to day-to-day practice. To complement the technical theme, Simon did talk about the non-technical clinical skills, and I think, Simon, you need to ask Ahmed about his choice of music, but maybe not in front of everybody, but I think this is something you need to ask him. I'll leave him to answer this in time. And thanks very much for the judges, Chin Gupta and James Kenross and Krishnan Murthy, and for scoring the abstracts by Pierce, Shiraz, and Sarah. And it's a pleasure to listen to the talks, to see you, although virtually, and from Amsterdam, from the States, from Edinburgh. It's still a UK part of UK, Simon, and hopefully we'll see you in person next time. And Ahmed, well done again, you and Wendy and Benji, and congratulations for the good work. Thanks everybody.
Thank you and bye-bye.
Bye.
Thank you, everyone. It was a pleasure.
Thank you.
Bye.
Bye.
Thanks. Well done. Well organized.